Hello, everyone. Welcome to another episode of the Good Insights podcast, hosted by me, Alison Cantor. I'm excited to announce that today our guest is clinical academic Dr. Sabena Jameel.
Hi, thank you so much for having me on today. It's a real honor. I look forward to talking to you.
Thank you. So, first, I would like to give more of an introduction about Dr. Jameel. So, Dr. Jameel is committed to looking at humanistic innovation in medical education and in practice, all with moral flourishing underpinning the goal. She completed her undergraduate medical degree at Nottingham University. Her junior house officer training or residency was completed in Nottingham and Derby before coming to Birmingham for general practitioner specialty vocational training, also known as family medicine training. It was after GP training that Dr. Jameel realized her passion for medical education. She completed her Master in Medical Education at Warwick University. Her dissertation focused on knowledge management in primary care, looking particularly at tacit knowledge exchange or mind lines, and how much of what doctors learn is from conversations in the coffee room or water cooler, rather than explicit knowledge in textbooks. Her master's degree also stimulated an ongoing academic interest in metacognition. In 2006, she became the sole training program director for the North Birmingham GP training scheme. It became and remains a very successful training scheme. In 2011, Dr. Jameel became an Associate Dean for Health Education England, working across the West Midlands. This included responsibility for residents working in family medicine and for family medicine specialty training from 2013 to 2020. Dr. Jameel is now very immersed in learning and teaching on the subject of phronesis, also known as practical wisdom in medicine, which aligns very well with her new role at Birmingham University Medical School, leading on medical professionalism. Dr. Jameel recently convened a British Academy-sponsored conference on laughter and medicine. Dr. Jameel has additional roles as the medical school academic quality lead and leading initiatives in equality, diversity, and inclusion. Dr. Jameel holds trustee and advisory roles with the Della Fish Foundation, West Midlands Police Professional Standards Group, Wesleyan Financial, the Royal College of General Practitioners, National Ethics Committee, and the Human Values Forum. Wow, it's great to hear everything you've already done, Dr. Jameel, over your professional career within still a short amount of time. And I'm so excited to have you on today and talk to you more. And my first question for you is diving right in already to some articles and research you already done. I noticed in your article entitled Wise Doctors, What Can They Teach Us About Flourishing? You cite Dr. Barry Schwartz and Dr. Kenneth Sharp when you write, phronesis is about doing the right thing at the right time for the right reason. And you continue to explain it is inherently contextual, and this is in contrast to the generalizable reductive rules, guidelines, and protocol-based approach to clinical medicine. Can you expand upon what phronesis means, particularly in this context? I imagine it may be a new concept for many people.
Yeah, absolutely. And I think sometimes words can put people off, and phronesis may be one of those words because it's obviously an ancient Greek word. But the bottom line is it captures something quite special. It gives us a word for something that may not have been captured in our normal vocabulary, and that's practical wisdom. That's what it's quite commonly translated to. And it just focuses and it helps us bring together lots of different sources of information that help us adjudicate when various things are conflicting. So phronesis adjudicates when values conflict. And we know that certain points, the rules don't give us what we need, for example. So some organizations might use rules and incentives to try and control and regulate what's happening. But ultimately, if we apply the rules too frequently, we are eroding the skills, people's developing their own skills. And if we use too many incentives and that becomes the norm, then we are eroding people's ability to do it out of their own volition or their will. So rules and incentives can erode the will and the skill. And that's nicely captured in Schwartz and Sharp's book on practical wisdom. And we'll probably talk about this a little bit later. But if I was just to use laughter as an example, specifically in a doctor-patient interaction, it could go horribly wrong. we know laughter is quite an immediate vocal thing that we can respond to and is a response to what's just happened preceding it. But it could be used to humiliate somebody. It could be used to make somebody feel very bad if the intention has not been correct. So you need the right sort of moral intention, you need the right context, you need the right moment for it to be used in a constructive way that builds trust. So that is just a small, possibly reductive example, but we all know that timing is imperative when it comes to appropriate laughter that helps generate and bond doctor-patient communication.
Thank you. Yeah, that's a great example to think about in the moment when a doctor is talking to a patient, what they should do, and using phronesis or practical wisdom to think about what to do or what the best response might be.
And I think
And
also it's really difficult to put down a page full of guidelines of telling people when to laugh. It wouldn't work, would it? It's a very spontaneous, rooted in emotion. There's so many things at play here. And if somebody wrote you some guidelines on how to make your patients laugh, it may be good as a guide, but it's nothing more than a guide.
yeah, no, for sure. I definitely could see that being quite difficult. There's only so many things that you really can write down and say, do this at this time, when in the moment, who knows what's going on in the patient's mind and what the specific condition that the patient is dealing with or the specific problem they're dealing with at that time. And it's hard to know what's going through the patient's mind in that moment, whether they're nervous or excited to get answers or they're thinking about other things. So I definitely could see how that's more like an in the moment training kind of thing.
Yeah, and the beauty about phronesis or practical wisdom is that it appreciates that rules don't always cut it and they're sometimes deficient. They're helpful in guiding us. And essentially, it then enables us to start thinking more about things like our character and our professional virtues. And essentially, that's what I'm hoping by having these conversations and by teaching phronesis within professionalism curriculums, that we can get people to appreciate the beauty of context and contextual judgment and clinical judgment.
Yeah, for sure. That makes a lot of sense. And I wanted to, going off of this topic, I really wanted to ask you what inspired you to study phronesis within the medical field?
Okay, so this is really interesting because I absolutely didn't know what the word phronesis meant up until 2013. And what happened was I'd finished my master's degree that looked at, as you've mentioned before, the metacognitive aspects of learning. It's the sort of invisible stuff and the stuff that we learn without it being explicit in curriculums, so very much like the hidden curriculum. So I began to realize when I was surfing the web that there was a new research center that had opened at Birmingham University called the Jubilee Center for Character and Virtues. Totally fascinated me. And I'm thinking, oh, they're doing some really interesting stuff. So I arranged to meet the deputy director, Professor Chris Jansen, and had a chat with him. And in his wisdom, he is an educational philosopher, a very well-renowned one. He said, Sabina, you need to study phronesis. And I thought, you what? What's that? What's he talking about? How can it be that important? I've never heard of it before. But he was absolutely spot on because as soon as I started reading more into it, I thought, this is it. This is giving me a vocabulary for something that I have thought has been missing in medical education all the way through my own medical education. And I felt excited, to be honest. I felt excited that I wasn't going mad. It wasn't me thinking there's something missing in medical education and I don't know what it is. It's like a wonderful light bulb discovery. And from that point on, with the guidance of Professor Chris Jansen and June Jones, my supervisor, went on to do a PhD that looked at enacted practical wisdom in family doctors. And it was a beautiful experience, basically identifying wise doctors and taking their life histories and seeing what motivated them and how they lead the lives they live and what we can learn from that.
That's amazing. I love how you set up the conversation and this person was telling you, oh, you need to study this, but you hadn't heard about it before, but you listened and you really looked into it, ended up really studying it. That was for your dissertation. Am I I'm
Yeah, so for
yeah.
my PhD thesis, but I
Mhm.
have subsequently presented some of these ideas to now thousands of working clinicians. And for the majority of them, they too feel somewhat enlightened by the fact that there is this language now that captures what's missing, in that sometimes we feel that we slavishly have too much bureaucracy to do and it's too much about accountability, and we're losing the moral grounding of medicine and the value of the relationships and the genuine interactions with patients rather than it becoming transactional. And as soon as I start to convey these ideas in presentations, you can see that it really does bring back the passion to a lot of the clinicians that I speak to. And
Mhm.
actually, I've spoken to patients as well, and they love to hear this too because they know how important it is for good clinical care.
Right. That makes a lot of sense, and I'm happy to hear people are receiving it well when you start presenting it, and once, get the ball rolling, you present it to someone, someone else will hopefully credit you and tell someone else, and they'll read more into it. So that's great. You've already been presenting it to thousands of people, and they've liked it. And my next question relates to this, but also the answers you were giving before to the question even before that. How can we properly prepare medical students in the classroom for real life situations where they face difficult ethical decisions? And what process have you found to be most successful?
I think both anecdotally and in the literature, when you're trying to prepare a group of learners for difficult situations, particularly ethical, you need to create safe spaces. And those safe spaces usually are conducive to small group work where you hopefully with the same people for at least a few weeks. So you get to learn to trust them. Because ultimately, when somebody has an ethical doubt, they also feel vulnerable when they maybe want to find out how to navigate that. They're scared of feeling stupid or not knowledgeable enough or a bit of a fraud, really. So creating safe spaces is the most important thing we can do. And as educators, we need to be able to have not only the sort of character aspects that help nurture those kind of conversations, but you literally need the logistics as well. You need the room space, you need the facilitators, and you need the educators all to be on the same page with regard to supporting medical students. Obviously, I think it's more than just having a discussion about difficult ethical decisions. It's easy in theory to know how you stand on a certain issue, but then when you're genuinely facing it with a patient sitting in front of you, that could be a whole different matter altogether, because actually you might feel quite emotional about it. You might feel a little bit triggered about it even. And it's about how do you manage your emotions in that moment when it's happening. And sometimes you can't second guess, or I guess role play has a role, but it can be a whole different thing when you've got a real person, a real situation, possibly a whole family and a whole community looking to you for some solutions to this ethical dilemma. I also think that we should break down some of the hierarchical barriers between teacher and learner, because that is again a barrier to students being honest with you, and asking some of the difficult questions they want to ask you about how to approach something. So it's not easy by any means, but it's very rewarding when you see the fruits of it done well.
Mhm. Yeah, I think that's huge, the idea of breaking down the barrier between the the teacher and the learner. I think that relates to the lesson plans, not that they relate particularly to medical education, like students learning to study medicine, but like in our lesson plans, we're also breaking down that idea of, oh, the teacher is the only one with the expertise and the students are the only ones that can learn from the teacher, because the teacher can also learn from the students and they're thinking about different ethical dilemmas. And also going back to your point too of it's very different in the moment to be dealing with a patient or a whole community or family members in a room dealing with a really difficult situation, and to see how a doctor responds versus telling the doctor how they could respond in textbook examples. And for my sorry, did you want to talk more about that too? If not, I had more questions.
I guess I just wanted to follow on from the question that you asked, and I would say there's been more of a focus on the doctor looking after themselves. There is
Mm,
this analogy that when the plane's going down, you have to put your oxygen mask on first before you can go and save everybody else. And I think that really has been, particularly post-COVID, a really important message to people. And I think some of my medical students now, the younger generation, are quite attuned to this. They know when they're feeling tired, they know when they need to take rest. And I think that's actually quite a positive thing, because it's too easy to just bury some difficulty you're having and then it rears its ugly head some time later when you're going through some kind of crisis. Another thing, just on the point of ethical decisions, sometimes we can't face some really challenging ethical decisions. And I find that literature and theatre and film, so essentially the medical humanities, can help us understand the plight of people in situations we could never really imagine. So, for example, the plight of an asylum seeker, the plight of somebody who's a victim of domestic violence, we may never know unless we engage with literature or cinema or whatever it is. And that, again, I think helps develop our empathy and compassion to help us do what we do and practice medicine better.
mm. I think that's great. That's awesome. And does your role of being a professional doctor following certain standards ever conflict with your need to use personal judgment? I feel this continues to relate about what what you're doing in theory versus what you're doing in practice, the standards versus the need to use personal judgment.
Yeah, and I think clinical acumen and clinical judgment is really very important. And yes, when I at the very start of the podcast, we spoke about phronesis adjudicates when values conflict. So being able to refine this, and I'm not saying there's a perfect state, and I and many others may never get there, but at least the aspiration to try to learn how to do this better is a noble aspiration for our continuing professional development. So yes, often I would say the professional standards conflict with the need to use professional judgment. Just some examples that I try to think of to try and depict this for you. For example, I had a patient who he was seriously in need of having to go to the emergency department, but he was seeing me in my primary care clinic, and I was trying to insist that his particular condition required urgent assessment in the emergency department, to which he said, I have no money. I have no money to get there. He said, and then I said, can nobody take you? Have you got friends, family? And I knew it wasn't the kind of condition where I had to dial 911 or 999 to get an ambulance straight away, but I did know he needed to be seen. And then in that moment, in my consultation room, he said, Doctor, can you give me some money? And I just thought, oh, okay, that's really strange. Nobody's done that to me before. I in the UK, obviously we have a national health service where money's not really exchanged at all between doctor and patient. So they don't pay for the services, and doctors don't certainly give money to their patients. And I thought, I don't know how to deal with this. The rules will say I can't give him any money, and I understand why that's a perfectly valid professional regulation, a professional rule. But then I thought, oh my gosh, he really does need to go to get this assessment in the emergency department. So I went to reception and I had a chat with the receptionist and negotiated with her for her to tell the patient that there is a small emergency pot of money owned by the surgery that will pay for him to get a taxi to go to the emergency department to get the care that he needs. So I sort of skirted the issue of giving him the money directly because that would compromise our relationship, but made him think that it was the surgery that had a little pot of money that could help him get the taxi. But it was in fact my money, but I didn't want him to know that. So
Mm,
that's one example. Another example is actually totally the flip side of this, and it surprised myself. So I've been a doctor for 28 years now, and about 5 years ago, my own father died. And that's always a very difficult time in somebody's life when you lose a parent. I didn't take any time off work, surprisingly, because the one thing that made me feel normal was going to work and going to the same four walls that I knew and made me feel normal because nothing else in my world seemed normal. And there was an emergency patient put on my list, and it was a woman about the same age as me. And under that, it said she needed a sick note because her father had just died. And I thought, I don't know if I can do this. I don't know if I have the mental strength to talk to somebody else about their bereavement when I'm going through the same thing. Anyway, we couldn't find another doctor to see this patient, and I saw her. But what shocked me, to be honest, was I was able to be on almost an automated mode to do my professional job. And it didn't affect me emotionally. And I was quite stunned by that. And I don't know if it's because it's so rehearsed and I've been doing it for so long that there's this other persona where I was able to do that. But I just wanted to show you the two different examples where sort of self and professional blur a little bit, and how it's important to understand the boundaries, professional boundaries, that we sometimes have to circumvent, but still remain as professional as we can be.
Wow, those are two specific but amazing examples of very different and both difficult ethical situations that I would have never thought about in the moment. The patient, specifically in your first example, asking for the money, which I guess makes sense because you're saying they need something and they say they don't have money and then they feel desperate. But that was an interesting way to talk to the front desk and frame it. So you're being very charitable yourself, really wanting to help this person and like do the right thing in your heart, but also think about yourself as a medical professional, not wanting to compromise the relationship. Especially thinking about how would you handle it later than with other patients if had come up that you had done this. I don't know how they would find out, but just thinking about your other patients as well. And then in the second example, I'm so sorry about your father, and that is so difficult to then have to talk to someone not as a friend to friend, but as a doctor to patient, and the way sometimes people, and as you did, are able to just power through and put themselves in the mindset of their profession and not their personal life in the moment is of course extremely difficult but incredible. I don't per se know if I would have the strength to do that if I was in your position, and many other people I don't think would have that strength. So that's very impressive. And you were saying before too, I don't know if I responded to this, but when you were saying about when you were talking to students too, it reminded me because of what you were saying about taking care of yourself emotionally. Students are much more attuned now since the COVID-19 pandemic to think about, oh, are they too tired? Do they need more sleep? Do they need more exercise or whatever to make sure they're able to not just do their job as like a student, but also do their job if they're in residency or they're now a practicing doctor. So
It
thank
really is like a long haul, and you
you.
have to almost conserve your energy for the long haul and not burn out quickly. And that in itself is an art, knowing how to look after yourself. Um, I have conversations with my children, and some of them have done all-nighters at university. And I'm thinking, why are you doing that? You'll just feel rubbish in the morning. And I remember being a medical student. Well, I never did an all-nighter because I knew it was a long haul. And actually, you need the stamina to be able to keep going for months on end. And so you need to check in regularly and have small doses of rest and replenishment. It's just not burning out over one night. That's
Mhm.
not that kind of career.
Mhm. I agree, even just with anyone in any field, especially for medical students and for doctors. But I've also been told that about by wise people around me, people my own age or people much older than me, and they've said the phrase, it's a marathon, life is a marathon, or work is a marathon, not a sprint. And
Mm.
I really took that to heart, whether it be for doing a 9 to 5 job or doing things outside of work, making sure me and my all my friends and everyone around me is staying healthy because Yes, I don't know how some people pull all-nighters. They do it. Maybe somehow they recover in a day, but not for me. And I imagine I'm other people who do not recover from an all-nighter after just one day, unless maybe they just have a lot of energy or they're on a lot of caffeine. And I wanted to ask you, going back to thinking about people taking care of themselves since the COVID-19 pandemic, how has the COVID-19 pandemic made it easier or more difficult to create opportunities to help doctors and medical students reflect on what it means to do, quote, good work as a doctor? And how has the pandemic impacted the opportunity to practice, quote, good medicine, meaning work in this field that is engaged, excellent, and ethical?
I think COVID pandemic taught us many things, some of which I think has made some conversations easier. I think there's a greater awareness of mental health of professionals, a greater awareness of the signs of burnout, a greater awareness of what's causing moral injury, because sometimes working in under-resourced situations causes moral injury, making it really difficult to continue to work. So these things, these terms, maybe we were not familiar with before, I think have become quite common language, and even we're discussing it very much more in our medical school as well, and people are more aware of it. And I would say maybe less ashamed, because there's a lot of shame attached to taking time off because you're burnt out. I think possibly there's less shame attached to that. If you need to take the time off, take it off, because in the long run, like you said before, this is a marathon. We hopefully want you to resume, come back to work and do what you do. But in other respects, especially in this country, in the UK, things have become more difficult. So, as I mentioned before, most of us are employed by the National Health Service, which is publicly funded and supposed to be free at the point of care and serves the whole population of the UK. But because of the pandemic and the way that many surgical procedures and clinics were cancelled, we're at a situation now where in my primary care clinic, if I refer somebody on, I know they're going to be waiting 12 months or more to see a specialist. And this is so demoralizing. It makes me feel like I'm not doing my job properly because patients are not getting the timely care they need when they need it. And again, to a degree, that contributes to my feeling of moral injury. And I can't do this job anymore because how often do I have to deliver that message to patients? Sorry, I can't help you. Or it's going to take 1 or 2 years before you get your hip replacement or your knee replacement. And in the meantime, we just have to manage the pain together. So some of these conversations are really difficult. But I think one really important thing that the pandemic taught us, particularly in the lockdowns, is becoming attuned to what's important to us. And quite often people then realized it was friends and it was family and it was sometimes nature and it was sunshine and it was a humble cup of coffee. These small pleasures we became more aware of because our very, very busy, hectic lives and schedules had to slow down. And I think that is potentially a very positive thing. And in those moments of reflection, many people began to think about, well, what do I want to achieve in life? What do I want to do? For some people, that made making quite serious decisions, like completely changing track of their careers or whatever. For me, actually meant I got my PhD written, which was a huge aspect of procrastination in my life. So that felt rewarding. But ultimately, if we go back to the very original conversation where we started with what's phronesis? Phronesis is practical wisdom. Practical wisdom, Aristotle said, is the root to eudaimonia. And eudaimonia is flourishing. And and here what we're talking about is attending to the tools and the things you need to implement to help yourself flourish, but also to help others, i.e., the community flourish. And so that in itself is a quest towards good work. And if we are on that journey towards thinking, okay, what's going to help my own well-being, what's going to help the well-being of others, um, I would say that's a noble aspiration, and that is what good work is. And it's about finding meaning, doing work that's engaging. Quite often it's about service to others, so that we then feel that we've lived a good life. And actually that's the goal of virtue ethics, which is what all this is rooted in.
Right. Thank you for explaining all of that. And one thing I did want to touch upon that was interesting you said about people feel less ashamed to take time off for themselves. I know in the US, especially I'm talking as someone from the Northeast, very, I would say, faster pace, work, work, work culture. People are trying now to be better at taking time off, or managers, I think, are being, I don't know by everyone, but maybe in certain fields told to welcome their employees to take vacation time, even though I know the vacation time that's given for different fields in the US is, I've heard, much less than generally European countries. Europe is very vast, many different countries, but it's interesting how even here it's been coming to of telling people, no, take time for yourself. You'll be better when you come back, which has been wonderful. And thinking too about that concept of with Aristotle, the quote, eudaimonia is wonderful too. And I think it gives like a lot of food for thought. And thinking further about how medical students and doctors are getting through these long days and having to put a lot of physical strength and emotional capacity into their work. I wanted to ask you, physicians and residents, or for our listeners, people who are still in training, often experience days that are long and challenging, both physically and emotionally. As I'm saying, is there an opportunity to come together to reflect and to continue to improve their work? And if so, how?
Yeah, so it very much fits into what you were alluding to. Sometimes to be most productive, it's not about working non-stop. It's about pausing and having rest, because then in the time that you are working, that time is more productive.
Mm.
Therefore, I think our organizations, be it higher education or the health institutes in which we work in, should at the highest level advocate for built-in time for us to reflect, preferably together. So in some of the organizations that I work with, maybe primary care clinics, they have something called huddles. Huddles are maybe a 10 to 15 meeting, often while you're stood up, whereby people just get the chance to talk to each other about the stuff that maybe they found challenging, they wanted help with, or somebody else can give them advice on. And just that little touch base makes a huge difference to your whole mental attitude for the rest of the day, because you feel somebody's on your side, you're here to support each other, and you get the real feeling of teamwork. Equally, Schwartz rounds, which I'm pretty sure the Americans do, we certainly do them here, more so in the hospital trusts. And we have other gatherings such as Balint groups. Balint was a psychoanalyst, where quite often he would allow GPs to, in small groups, be able to talk about a difficult case. And actually, what's fundamental about this is they're not talking about the difficulty in managing the case clinically, they're talking about the emotional difficulty. Maybe some barrier or some feeling they had that was an obstacle or they didn't quite understand. And then they get the peers, the other GPs in the group, to offer reflections on how they interpreted it. And often within that discussion is some solutions. And obviously now we're more connected than ever on social media. And I know that a lot of the doctors that I talk to, because I'm an appraiser as well, so every year I meet doctors who fill in portfolios towards revalidation, which is for the General Medical Council. They find a sense of community in things like WhatsApp chats, where they just sort of offload, obviously in a professional way. They don't disclose patient confidential information, but it's that feeling of collegiality, that feeling of support. We simply must do this. I think it's quite isolating when you realize you're a clinician with no support, nobody to talk to. So we must find these, and actually our organizations must put in the engineering structures, as it were, to help us do this.
Mm. Yeah, I think this kind of thing is something we do at the Good Project as well, with getting these meetings together with teachers from out the world to talk about not just the Good Project lesson plans, but teaching strategies. And even at the Good Project, we're doing meetings with other colleagues from other universities to think about the challenges in our research and our work and how to improve what we're doing. And I hadn't really heard about these kinds of groups in different fields before I came to the Good Project and Product Zero, and it's been really interesting to learn about. And for the now the medical field I'm hearing about it in, and for the field of education, I wonder what other fields they're doing this in, or where it could be put in more. Just some food for thought for myself and for us in this conversation, and thinking too towards all this reflection and thinking about how to teach each other how to, whether it's the medical field or the education field, how to get through the day physically and emotionally. I want to look more towards mentorship, and what does a good mentor look like in the field of medicine?
I think it's going to be common to what a good mentor looks in any profession, or maybe not profession, but I've had some informal mentors in my career, and I think one of the most valuable things that I've felt has helped me is that they're genuinely curious and interested in me as a person. They seem to have this unconditional positive regard where they're not in it from themselves. They really genuinely want you to do well, and therefore are supportive and encouraging. Quite often they're a role model themselves, and their insight and their wisdom gives us messages, maybe not direct advice, but helps us to think in a broader way. So they don't necessarily tell you what to do, but they guide your thought process and remain relatively neutral and kind of observe and they allow you to bounce ideas off them to explore further where your thought process is taking you. They're obviously usually good communicators, and they do listen attentively and give constructive feedback. So they're like that sounding board. And quite often they're open-minded and approachable. I tend to find they are quite optimistic. There's nothing worse than a naysayer saying, you can't do this, you can't do that. Oh no, don't do it this way, because that can be quite demoralizing. And I like the little phrase, uh, and actually they use it in improv. So improv training is yes, let's. So when two people say, yes, let's, there's an immediate bond and an immediate sort of feeling of, wow, somebody's with me on this. And that immediately gives you some optimism to talk further. So yes, let's explore. And I like that mentality when it comes through in a mentorship relationship. And actually they tend to be very giving. So it's not about them ascending some promotion ranking. It's about them genuinely wanting to lift and elevate you, give you a foot up. And ultimately, it's very rewarding to watch people grow. So as a mentor, the reward is in watching the growth of others and seeing that spread, their influence spread.
Yeah, I definitely think for it sounds like you're saying with the mentors, it you have to be in it because you want to help the person. It's not for a financial gain. Although I imagine there might be programs set up where people get stipends in like a formal mentorship program, but I would assume usually not. But I've been in similar situations too where you're trying to talk to someone or a past professor and they're not telling you what to do, but they're helping guide you. And I think some people might want people to tell them this is the decision you should make with your next career step. This is the decision you should make of how to write this paper. But it's much better the approach of guiding someone, giving them suggestions, and getting them to come to their own understanding of what they should do next. If not, I think it's much harder to learn and to grow and to flourish. And it sounds like it's the same in medicine too, to help someone to have someone guide you versus tell you this is what you should do is a much better situation.
And again, it goes back to the conversation on context. Everybody's life path is different. So a mentor may have experience, and actually that experience is a very, very valuable source of information and knowledge, but it's not the only source. How else would we get trailblazers in this world if we all followed the same path everybody else followed?
Mhm. Yeah, definitely. And I think that can be it's a great thing, but also a hard thing because some people might want to say, this person did this path, they did this in this specific situation. How can I apply that to my life, whether it's in a different field or it's talking to a friend about a situation within their family or relationship, and this person's relationship or field of study could be way different. But yet you can still find the connections between different stories because we're all human and we all go through similar experiences. So I definitely feel like even the things that you're saying now in our conversation could be applicable to teachers and students. I think back to the example you said about the patient asking, well, can I have the money so I can do this? And I could see with maybe a teacher and like an older student, the student wants to be in a certain activity or do do a certain activity or go on a trip or something, and they don't know or look for the money or for the resources, and trying to find out ways of how to get there can be really difficult, especially in like under-resourced schools or populations. So I'm just making connections on the spot to things you said. I hope that's okay.
Yeah.
um and I wanted to ask you as well, you recently put on this, I heard, this wonderful conference, this 2-day conference on laughter and medicine. Can you tell us what that entailed? And I think our audience would be curious to hear about the presentations that were made or the insights people had during these wonderful discussions.
Okay, so this was, I guess, a risk, but it was a very exciting risk that I think paid off. 2 years in the making. We got some funding from the British Academy, which is a very prestigious UK social science humanities organization. And I was a convener, along with two conveners from Texas Tech University. So obviously across the pond collaboration there. But not only was it two different universities, it was transdisciplinary, which meant it wasn't just physicians. My two co-conveners, excuse me, were classicists. So one was comparative Russian literature and the other one was medieval French literature. So you're thinking, how on earth are people with those backgrounds going to do a conference? But the conference itself, let me just read you the little blurb that we put out there, because I think it will give you a good idea. So we asked the question, how does laughter in all its complexity impact on medical care, illness, well-being, healthcare providers, and patients? How does the history of artistic and cultural representations of laughter in medical contexts make sense of diverse medical experiences? And actually, we underpin this with the larger ideological, philosophical discourses. And so, just to give you a feel for the audience, so the conference happened last week on Monday and Tuesday in Birmingham. 25 speakers spoke at the conference, along with some of my medical students who did really brilliantly well at presenting posters at the conference. But delegates consisted of physicians, classicists, psychologists, neuroscientists, physicists, obviously physicians, improv actors, clowns, museum curators, comedians. So you can see it was a big, eclectic mix of people. And the themes of the roundtables and the presentations. So we looked at laughter as being a trust building tool that helped develop rapport between doctor and patient. We also looked at how laughter and medicine was depicted in history. So, how the ancient Romans maybe depicted it in some of their literature, how it was depicted in theatre and opera. And quite often, if you look at pre-Renaissance times, the doctor was often portrayed as the joker or the comedian or the crook. So, it was interesting for us to have conversations about that. There was another heading which related to laughter in relation to cosmetic procedures and oral health, and actually the psychological consequences of laughter that's inappropriate. Because essentially, we spoke about hierarchy between doctor and patient. A doctor could use laughter to humiliate a patient. So it's not all positive. And we did explore some of the darker side of laughter and dark humor in medicine as well. So we also had some art historians talking about the visual history of humor and health and how cartoons and caricatures and things like that depicted medicine. So you can just see how broad and wide and adventurous the whole conference was. But we've had overwhelmingly positive response, and we are hoping to get a book published related to the topic of laughter in medicine. And again, as I mentioned at the outset, I feel laughter is a really good specific example of how context is really important. And actually, the moral underpinning and the intention is also very important.
Of course. And it sounds like it went incredible with, wow, 25 speakers, including some students presenting their posters, and you even said comedians. It sounds like a wide variety of speakers and people that attended. I hope people check it out with I'll say this again later, but the hashtag LAM24 on X. I saw a lot of people tweeted using the hashtag and was very happy to see them spreading awareness about the different discussions that were had. I bet people would like to look into that hashtag and see the presentations that happened. And I want to ask, not my final question, but as we start to wrap up, do you have any resources you would like to share with people who want to learn more about phronesis and virtue ethics in medicine, or really anything we've discussed today?
Okay, so as mentioned before, I studied my thesis PhD at the Jubilee Centre for Character and Virtues at Birmingham University. So I would recommend the Jubilee Centre website actually, because there's a whole lot of information on phronesis and character in the professions, not just medicine, but also the legal profession, teaching, nursing, and there are some brilliant summaries and bits of research, great resources on that website. So I definitely recommend that. The Schwartz and Sharp book, Practical Wisdom, that's a really easy to read book, again, with some examples of the law profession, medicine. There's a good book called Practical Wisdom in Professional Practice. There are some clinicians actually over your side of the planet. So Professor Kaljian, Loris Kaljian, and Professor Margaret Plews-Ogan, they have written about phronesis in medicine, and I've been quite inspired by some of their writing. And more recently, some of you might know the Kern National Network that has started to do more work on flourishing in medicine. So they do some good work as well. So I guess that for starters. Also, if you Google my name, quite a lot of the stuff that I've written, that'll be available to you as well.
Great, thank you. And I love how you listed to it the Jubilee Center. You said people can find resources there for various different professions, which is wonderful to hear because I'm sure people listening are not just involved in medicine, but also education, perhaps legal profession, other things like that. And my final question for you is I think more of a fun question. Of course, everything we've discussed already has been quite interesting, but this is more a little lighthearted depending on how you take or what your answer might be. But I want to ask you, what piece of media have you turned to recently or in the past for inspiration? And this could be a piece of media like a podcast, a book, movie, TV program, or anything else.
Okay, so I guess it will be in preparation for the recent Laughter and Medicine conference. I came across a book that was written in the year 2000 by the former Chief Medical Officer of the UK and actually a former WHO chairman. That's Sir Kenneth Kalman. And the book is called A Study of Storytelling, Humor and Learning in Medicine. And I never knew such a book existed. And the fact that somebody was thinking about this well before 25 years ago and such a prominent figure as well. So actually just going through that book and the fact that even then he was able to bring in the importance of medical humanities and literature and humane medical practice. And I just thought it was totally fabulous. And we need to speak louder about some of these really important character and emotional aspects that make us ultimately love life and love humanity, if that doesn't sound too cliche, because I think it's really important to have that love of humanity to be a good doctor.
Mhm. I don't think that's too cliche at all. I think we could all use that no matter what the time is or what the year is. And that made me feel good to hear about that book personally. I'll have to look into it. Wow. Okay. And really cool. It was published in 2000, so people were talking about things even way before we thought they were.
It's a relatively unknown book, I think, and I think it's a shame because I'm now going to use bits of it in my teaching with medical students, just because I think it's fantastic and some of the ideas in there are fantastic.
Of course. Yeah, I think there's certain books in different fields or professors that that use to teach in certain subjects, and this is the literature we use. They say, these are the people we're going to read from, but pulling in new sources, even that are not super old, but that are they seem somewhat old now because they might be from 20 years ago or 10 years ago, but they're still quite relevant. And even to dig a little further back, like past the past 10 years, to see what people were saying about the subjects they're really discussing more in depth now is super interesting to think about the people that started talking about it earlier before these ideas became super popular and were put out onto the internet and became more widely accessible. So thank you for sharing that. Is there anything else you wanted to touch upon before we wrap up?
Well, only saying something really ironic, a lot of the work that I've been speaking about rooted in virtue ethics relates to Aristotle,
Mm.
and that Nicomachean ethics is what, 3,000 years old? And that still has value for us today. So I guess it's a plea to everybody to maybe realize that there is some really relevant wisdom in some of these ancient books that we can apply to our current contexts.
That's true. You should never forget about not just the people from 20 years or the people that from a long lifetime ago we're talking about. They didn't have the internet, but they had great minds and great thoughts, and I'm glad have been written down and discussed, but could be discussed perhaps even more to guide us in our ethical decisions and political systems and many other fields and different professions. So thank you so much, Dr. Meal, for coming onto the podcast today. I've really enjoyed our conversation deeply. And if you want to learn more about the Laughter and Medicine Conference, everyone, you can look up the hashtag LAM24 on X. And if you want to learn more about the Good Project, you can visit www.thegoodproject.org.
Thank you.